have stopped doing abdominal X-rays. And because of the insensitivity of the, abdominal radiograph itself. And but some centers do obviously do abdominal radiographs, depending on obviously what is agreed, in certain centers and stuff. I must also mention here that I'm not going to be talking about the erect abdomens, because erect abdomens, very few centers actually do, erect abdomens, because again, they say that a supine radiograph should be sufficient actually to give a diagnosis instead of doing those erect abdomens and things like that. So let me quickly talk about the indications that prompt people to do abdominal radiographs. So at our facility, these are some of the reasons as to why abdominal radiographs are performed. So we'll be looking at obviously toxic megacolon. Toxic megacolon, obviously, it's a fatal and dangerous condition that obviously when you see it, this has to be highlighted, so that at least the patient can be seen by the surgical team. Foreign body localization, again, is one of the reasons as to why those abdominal radiographs have to be done. Again, patients who have had gastric bands or anything interventional, line placements and other things like that, would be able to do an abdominal X-ray. CT, X-ray requests are rejected on site. Right upper quadrant pain and vomiting. Again, those are some of the reasons as to why we reject those abdominal radiographs. You might want to probably ask as to why abdominal radiographs are rejected out of facility when looking at abdominal viscous perforations. So ideally, it is difficult actually to see a perforation, on an abdominal supine radiograph, but I will talk about some of the things that you'll be able to look at when you do one. So ideally, an erect chest X-ray should be done instead to look for perforations. Basically, you'll be looking for gas beneath the hemidiaphragms and appearances like that. And then constipation should be a clinical finding. The doctors should be able to actually tell whether this is, a constipated patient is constipated. So X-ray should not be justification for doing those X-rays. So at our facility, these are some of the reasons as to why those abdominal radiographs can be done or can be rejected. Assuming that we all know our anatomy, so this is an abdominal radiograph, obviously depicting different types of regions where you can find certain organs. And on your left here, we do have, the kidney, the right kidney here. We know that the kidney is surrounded by fat, so we are able to see fat delineating the right kidney. We can also see fat around the liver here, so we see that liver obviously there. And then the left kidney is always, so it's there, we can see it well delineated there. And then we can see the spleen over there. And then you are able to see the psoas muscles. I'll talk about the psoas muscles as I progress. And then down here, we can see that we have nearly included the ischial So basically, this is an ideal abdominal radiograph, though we are missing the hemidiaphragms, down and up there. So, and then again, I'll talk about those features. And then we need to know, which abdominal quadrant and what sits there, so that when we are able to interpret these X-rays, we should be able to tell which organ is actually, involved. So again, this is another plain, abdominal radiograph. We can see that, the the small intestines are centrally located, so they will be actually around in the middle here. So, and then they should measure about 3 centimeters in cross diameter. And then they do have, the folds, the mucosa folds that run across them. And those folds are called the vulvi conventers. So the vulvi conventers run across the diameter of the small intestines, which are sit right in the middle of the abdomen. And then we do also have the large intestines, which are run on the periphery of the abdomen. And then they are quite long, and they tend to have the mucosa folds that do not run across the diameter of the abdomen, the bowels themselves. So those ones are called the haustra folds. So on the small intestines, we call them the vulvi conventers, and then obviously in the large intestines, these are referred to as the haustra markings, and they don't run across. So the transverse colon, ideally should measure about, say, maximum about 6 centimeters, and then around the cecum, the cecal area here, the maximum should be about 9 centimeters. Anything that goes beyond that, we start looking at things like, dilatations or possible obstructions and, conditions like that. So how do you assess that? Obviously, you start looking for air in the wrong places. This is very important to recognize. So you will be looking for things like pneumoperitoneum. Pneumoperitoneum is just the abnormal presence of air outside the peritoneal cavity. So in this case here, we do have air, on the chest X-ray, this air beneath the hemidiaphragm on the right side, and also the air on, below the hemidiaphragm on the right side here. And then we have the stomach here. We must be very careful when we are trying to, distinguish between gas in the fundus of the stomach and the air beneath the hemidiaphragm. So sometimes, people that are inexperienced might call air in the fundus as a perforation. So this has to be made clear, particularly if you've got a patient, whose fundus of the stomach is in close proximity with the hemidiaphragm. Sometimes some patients might have a condition called the Chilaiditi syndrome. Chilaiditi syndrome is whereby the large bowel interposes itself between the liver and the hemidiaphragm. So it normally, you normally see it around here. It should not be confused with, a pneumoperitoneum. When you're trying to assess for a pneumoperitoneum, even experienced radiologist, this Legras sign could pose a problem to really spot one. But I'll try by all means to maybe show you how it looks like, but it's really difficult really to see a Legras sign. And then you'll be looking for gas, outlining the liver. You'll be looking for the falciform ligament, or if you are able to see these structures, you'll be close enough to be calling out a pneumoperitoneum. And then you can also look for retroperitoneum. Obviously, retroperitoneum now becomes on the posterior aspect of the abdominal cavity. So in that case, again, you'll be looking for, you'll be relying on the appearances of the kidneys, on the posterior aspect of the abdomen. And then look for the liver again. When you're assessing the liver, you'll be looking for pneumobilia, or you'll be looking for gas in the portal veins. So gas in the portal veins becomes very, very fatal. This has to be picked up. You shouldn't be able to miss that. And I will show you how it looks like. So pneumobilia, again, it is more central in the within the anatomy of the liver. And the gas in the portal vein, it is actually peripherally situated. regular sign, it is a double wall sign whereby on the left here, we have the lumen of the bowel here, and then we do have the bowel walls here. So this is in a normal patient. There is actually nothing to suggest there is a perforation. On this image here in the middle here, we do have the bowel here, and then we do have the bowel walls, but we are able to see the bowel walls on either side, from the inside and from the outside. So if you're able to see the bowel wall from the outside and the inside, that becomes a regular sign. Let me illustrate this on this diagram on the right, on the far right. We do have the bowel wall, the bowel lumen of the bowel here, and then we have the bowel wall here, and then we have another bowel wall here. So we are able to see the bowel wall on either side of this abdominal radiograph. So this, I must admit, it's a very difficult sign to pick up. Even it poses a big challenge to see a regular sign on an abdominal radiograph because of superimposing bowel gas and loops of bowel. But they say that if you missed it on abdominal radiograph, obviously I wouldn't laugh at you. But there are other features that you'll be looking out for to rule out pneumoperitoneum. For example, we can see gas here surrounding the liver. So this is abnormal gas outside the peritoneum here. So this, look at how beautiful it has actually delineated the liver here. So this is actually gas outside the peritoneal cavity here. That is a pneumoperitoneum. So it becomes quite easy to see. But again, here you could argue to say that you are able to see a regular sign in that region here. It becomes difficult to see a regular sign, but you are able to see gas right outside the peritoneal cavity here. So this becomes one of the signs to look out for. This is the falciform ligament here. So the falciform ligament, I think it divides the liver into the left and right side. So the visualization of the falciform ligament on an abdominal radiograph like this one here is an indication that there is actually a pneumoperitoneum. So that falciform ligament, gas outside the delineating the liver, again confirms the presence of a pneumoperitoneum. Again, if you look at the, I think this is lithoperitoneum, I think. So we are able to see the outline of the liver, of the kidney, right? Look at the gas, abnormal presence of gas in the lithoperitoneal space. Each time you do an abdominal radiograph and you are able to see the outlines of the liver, you are most likely to call out erythroperitoneum because the liver, the kidneys are actually on the posterior aspect of the abdomen. This is a pneumobilia. Pneumobilia is just an abnormal presence of air in the liver. Particularly, it's quite central. It doesn't actually go to the periphery of the liver. So this is a pneumobilia here. Sometimes patients who may have pneumobilias will be those patients who have had maybe a recent, ERCP, they've had that kind of intervention. So they would definitely have, abnormal presence of, air in that. Notice that this patient has had an ERCP, possibly with a stent placement, in the biliary cavity there. Yeah. Down here, we have, look at how beautiful this has, demonstrated air, throughout the liver, and it extends right to the periphery of the liver. So this is a classic example of air in the portal vein. When you see this one here, this, is a very dangerous finding. this patient has to be seen by the surgical team as soon as possible because this is actually quite fatal. Normally, it could be that somebody could have, pneumatosis coli intestinalis, or somebody could have a very nasty infection that is causing, this kind of, scenario. When you see air in the portal veins, this has to be, called out. Okay, so over here again, okay, here again we have emphysematous pyelonephritis. This again is a very serious, condition whereby you see air, permeating through the parenchyma of the kidney. So this, is a very, nasty finding. When you see one, obviously this has to be called out. A CT scan, showing, emphysematous pyelonephritis. All this is air in the wrong places. Notice that, the left kidney here is nicely demonstrated. The parenchyma is quite okay. We can see the cortices, we can see the calyces, the collecting system, everything is well preserved. But on this other side here, we can see abnormal presence of air in the parenchymal aspect of the, right kidney, demonstrating that we have got, emphysematous pyelonephritis. Down here, we also have, a well circumscribed linear lucency surrounding the wall of the urinary bladder. Again, this is actually air in the wrong places. This again becomes another, thing that you need to shout out, because we do have again, emphysematous cystitis, air surrounding the walls of the urinary bladder here. These are common features that you can see on an abdominal X-ray. Largely, this is because of infection as a result of maybe bacteria, infection, as it were. So these are the causes of erythroperitoneum. So, somebody could have bowel perforation due to duodenal perforations. Somebody could have ascending or descending colon perforation, or even rectal perforations, as it were. Or, somebody would have had, surgery, surgery, and things like that. So sometimes you might get this kind of information from the patient's clinical notes, so that it helps you sort of to piece things together, before you even write your you conclude. The bowels, when you're assessing the bowels, it's important that you look for dilated small bowels and small and large bowel dilatations. You're also assessing for volvulus. Either it could be a sigmoid volvulus or it could be a sigmoid volvulus. So again, I'll differentiate these ones as we go on. Look for distended stomach. Distended stomach could be caused by somebody swallowing air, or somebody could have gas entering the stomach, and then it causes the stomach to distend. Also look for hernia. Look out for things like mucosa thickening, or mucosa edema, or bowel wall thickening. I'll talk about this. So look at this patient who has, the centrally located small bowels. They are well distended with, if we measure these walls across here, we have, dilatation of the small bowels, demonstrating the volvuli conniventus, really. And then we can comfortably say that this patient has got a small bowel obstruction because of the distension of, the small bowel, bowel wall, and the clear demonstration of the, vulvar conventers. Notice that, the appearances of that is like, you're stacking coins on one on top of the other. So that classic example here denotes that somebody has got a small bowel obstruction, which could be caused due to so many things. Actually, somebody could have had, a paralytic ileus, somebody could have had, ileocecal, junction. There could be cancer there. So many things can cause this. On the right here, we do have another classic example of a small bowel obstruction. Notice that we do have a sentinel loop there. We do have a sentinel loop over here. So this sentinel loop here, it is actually dilated, and we can see the centrally located, and we are able to see the vulvar conventers as well. So this becomes, small bowel obstruction. I must mention here, though, that depending on where the sentinel loop is, for example, here it is actually very close to the umbilical. Oh, sorry about that. My apologies. Can you hear me?
Yes,
Yeah,
sir.
we can hear you, sir.
Sorry about that. I'm sorry. I don't know. Did you hear me here? Yeah. Right. So basically, this is now the sentinel loop. I'm sorry if I'm just repeating myself here. This is actually a sentinel loop here. And then notice, therefore, that we do have this sentinel loop close, possibly to the umbilical lumbar region here, and then it is very close to the pancreas. So where you find the location of a sentinel loop, and then if you look at the organ next to it, it could be that this patient could have pancreatitis, actually, because the sentinel loop here is a bit closer to the pancreas. If this sentinel loop was actually closer to the right iliac fossa around here, this sentinel loop you would be right to suspect appendicitis because of the location of this sentinel loop. So sentinel loops can be used to actually come closer to what is causing that sentinel loop. So in this case here, you would definitely be right to say that I think this patient could have, pancreatitis, and then you'll be right to do an ultrasound scan, possibly to see whether, somebody has got, pancreatic calcifications or, things like that. So you'll be right to do an ultrasound scan. If it was around down here, you would be right to suspect, appendicitis. Appendicitis. Okay. Let me go back to this one here. Again, gallstone ileus. A gallstone ileus is, some books would call it a Rigler's triad, depending on which book you have read. Some people would call it, Rigler's triad or a gallstone ileus. So a gallstone ileus is just a combination of three things. It will be a pneumobilia, which we can see up here. So a pneumobilia, we can see it over here. Then 2, we do have a small bowel obstruction. Look at that, centrally located, loops of small bowel. And then you can see a gallstone. A gallstone is actually right in the iliac, right in the sort of sacral area here. Sometimes this stone could be anywhere. It is believed that sometimes a patient could have a fistula between the gallbladder and the small bowel. So the stone actually moves from the biliary tree, and then it goes into the small bowels through a fistula. Or sometimes the stone could actually find its way through the biliary tract and through the papilla of Vata, and then it empties itself into the small part, or this first part of the duodenum. So you would see it possibly up here. So when you see pneumobilia, small bowel obstruction, start looking for a stone. You might see a stone anywhere, within the pelvic, the abdominal cavity, and then you'd be right to call it a gostonilias or a Riglas triad. Large bowel dilatation or obstruction, these are some of the causes. Colorectal carcinoma, diverticular stricture, fecal impaction, and the volvulus can cause large bowel obstruction or dilatation. So look at that. We have the peripherally located large bowels that have been distended beyond the measurements that are decoded earlier. So you see that this could be more than 6 centimeters. So there is dilatation of the large bowels, the splenic flexure here, transverse colon, and then notice also that we have lost the haustra markings. The abdomen, the bowels are really straight. We have lost those, haustra markings. So this becomes a large bowel obstruction. And notice also that it is actually lying to the periphery of the abdomen. Over here too, on the right side, we also have, sorry about that. We also have, again, dilatation of the large bowels, and with the gaseous, distension of the large bowels. Notice that we don't have any fecal matter, in these bowels. So basically, this patient is actually obstructed. To see whether this is perforated, it becomes a bit of a problem on an abdominal X-ray. So this is why you may need to do an erect chest, chest X-ray, abdominal erect abdominal X-ray is not really, many centers have sort of run away from doing those ones. I think I would advocate for a chest X-ray just for you to rule out a perforation. Look again here. We do have distended loops of large bowels. We have lost the haustra markings. So this is dilated again. We don't know the source of the obstruction, where the obstruction is, but we can also notice that there is actually a combination of the two obstructions: small bowel obstruction. Look at the vulvi conventers. The small intestines are also dilated, small bowel obstruction and large bowel obstruction as well. So this patient obviously might need, surgical review. Okay, volvulus is just a twisting of the bowel on its mesentery. There are two types of, volvulus. We have the sigmoid volvulus, and we also have the cecal volvulus. And then all these may result in a bowel obstruction and the bowel ischemia. Bowel ischemia becomes a very urgent thing that you need to pick up. If you don't pick it up, somebody's, bowel walls might start necrotizing, and obviously it becomes a surgical emergency. So what happens is that the large bowels, they will twist on their own mesentery, and then for a sigmoid volvulus, you have what is called a coffee bean appearance. So this is what is called the coffee bean appearance. We have a distended sigmoid. We have lost the haustra markings, and then all this is a twisted, sigmoid, because it has twisted on its own, and then it causes an obstruction. So beyond the obstruction, you don't see gas in the rectum here. So there's the absence of gas in the rectum because of this volvulus. Again, here we do have the presence of a sigmoid volvulus. It has twisted its own on its own mesentery. It is arising. Normally, a sigmoid volvulus arises from the pelvis and usually points towards the liver, to the right upper quadrant. So it arises from the pelvis and points in that direction. So this, with a coffee bean appearance, that becomes a sigmoid volvulus. Remember the complications here. It will cause an obstruction, and then it may also cause bowel ischemia. So each time you see a sigmoid volvulus, look for bowel ischemia as well. It could be present. Again, this is the cecal volvulus. A cecal volvulus, arises from the cecum here on the left, on the right side of the iliac aspect of the abdomen, and then it flips to the left side of the upper quadrant of the abdomen, and then it presents like a fetus. So this is most like a fetal presentation of this cecal volvulus. It will arise from here, then it flips over to the other side. So this is the cecal volvulus with a fetal paw kind of presentation. So when you see sigmoid volvulus, that is the cecal volvulus. And the presentations are totally different. We have a coffee bean appearance here for sigmoid, and then we also have a fetal presentation of the cecal volvulus. When you see these ones, again, look for obstruction, look for bowel ischemia as well. Look at that. This patient possibly has had, air intubation, and then look at how distended how gaseous and distended the stomach is. So this could be caused due to one, urophagia, which is actually a patient, swallowing, gas, or they could have been intubated wrongly, and they may also have a duodenal mass, which could be obstructing the outlet, the pylorus, the pylorus and things like that. So the patient becomes, obstructed because of that. So that, when you see it again, you might want to call it out. Hennia, again, is, if you look at this X-ray here, we do have, if I draw a line from the iliac crest here, and then I go down to the pubic symphysis around here. So that line, if I draw it around there, this is where the ligament is. The ligament is there. So sometimes there could be a weakness in the ligament here, so which will cause herniation of the bowel loops through the ligament. So we can see here that we do have bowel loops of normal bowel below the ischotuberosity on the right side. This is abnormal finding here. So this becomes hernia or inguinal hernia because there is actually, air being seen in the wrong place, and then that is the wrong place where we are able to see the air. So this becomes, inguinal hernia there. On the other side here too, we do have, abnormal presence of air on the left side here. Again, inguinal ligament, if we draw a line across there, we are able to see that, this patient has got loops of multiple bowel loops below and at the left ischotuberosity here, raising the possibility of an inguinal hernia as well. So when you do an abdominal X-ray, if you do an X-ray and then you cut it across the symphysis pubis here, the superior border of the symphysis pubis, you will not be able to see any herniation of bowel gas below the below that. So I would prefer that when we do our abdominal X-rays, we include at least the lesser trochanters and things like that, so that we are able to rule out any evidence of inguinal hernia. Bowel wall inflammation, again, when you do these ones, you want to see the inflamed bowel walls, and then you'll be looking for things like ulcerative colitis. You'll be looking for things like Crohn's disease. You'll be looking for things like ischemic bowel and other infective infections within the bowel wall appearances. What are the radiological signs we'll be looking out for? So you'll be looking for things like, bowel wall thickening, which I'll demonstrate, I'll show you. You'll be looking for things that support bowel wall thickening, like, thumbprinting. You'll be looking for a featureless bowel and loss of formed fecal matter in the left-hand side of the colon. So if we look at this X-ray here, we do have the transverse colon around here, but within the transverse colon here, we can see that the walls are very thick. So these are thick bowel walls. We call it bowel wall thickening or thumbprinting. If we say this is one thumb here, and another thumb here, another thumb here. So this is what is called thumbprinting. So thumbprinting is an example of, it's a sign of mucosa thickening. So look at if I draw a line from here to there, that is the bowel wall here. And then from here to there, that is the bowel wall. So all this is actually thickened. This is all thickened because of mucosa edema. On the descending colon here, we see that the bowel walls are again inflamed. So, and then we have lost the haustra folds. This becomes very, very straight, and which is what is referred to as a featureless bowel. So this is featureless bowel. Some books will call this one as a lead pipe appearance. So there is a thumbprinting, bowel wall thickening, and featureless, descending colon, demonstrating that we do have inflamed or bowel or mucosa thickening, secondary to ulcerative colitis. Patients like this, they tend to have a bit of diarrhea, when they present, when they do an X-ray. In fact, their fecal matter would actually be slippery. So when you do an abdominal X-ray, you'll be looking for things like I've mentioned here. Notice also that on the ascending colon here, we do have a remainder of the fecal residue here. So that again is supporting the fact that we do have a feature to support bowel wall thickening or ulcerative colitis in this case. Notice this one here. We do have a featureless transverse colon, which is demonstrating bowel wall thickening. So all this is thickened because of, again, mucosa fold. If you go to the ascending colon again, the walls here are all thickened. So this is an example of mucosa thickening, possibly due to ulcerative colitis. Again, transverse colon, here we see that we have lost the haustra markings, and then we do have a clear demonstration of bowel wall thickening. Similar here, we can see bowel wall thickening and thumbprinting, demonstrating that we do have, mucosa thickening here. Same as this one here, mucosa thickening, transverse colon. It is always, affected the transverse colon and not sometimes, and the descending colon, where we can see that, there is actually a featureless, descending colon here. We have lost the haustra markings. It is more straight. We call this the lead pipe appearance, demonstrating ulcerative colitis. Toxic megacolon, again, becomes this medical emergency. This can be very acute, actually. And this is why sometimes when patients have had, bowel obstructions, people tend to do mucosa thickening. When people have got bowel wall thickening or ulcerative colitis or Crohn's disease, doctors are always worried about the possibility of ruling out a toxic megacolon, because this can actually come up without notice. Could be in a very acute setting, so they will be repeating chest abdominal radiographs to rule out a toxic megacolon. How do you differentiate a toxic megacolon from ulcerative colitis? So basically what you should be looking out for will be pseudopolyps. They'll be more or less like, masses within the bowel wall, within the lumen of the bowel. So you will see so many polyps around here, irregularities, possibly to the walls of the bowel itself. Look at all these polyps, multiple polyps, within the bowel wall. So those ones are what are called pseudopolyps. Look at the thumbprinting. Look at the bowel wall thickening. So bowel wall thickening, thumbprinting, and all these polyps, pseudopolyps, when you see them, this is a classic example of toxic megacolon that has to be referred to the surgical team for them to intervene. Usually they cut off the diseased part, to save the patient's life. So usually the transverse colon is actually most affected. So what am I trying to say? What I'm trying to say is that each time you look at an abdominal X-ray, pay close attention to the transverse and descending colons. If for you to see, obviously maybe spot out mucosal thickening and the possibility of toxic megacolon. Fecal loading. Fecal loading, sometimes people don't do these X-rays for fecal loading, but because people request, depending on where you work, and then you are agreeable to do this one, you can do them. Look at the retention of semi-solid fecal residue here. It is consistent. Look at the round masses of fecal matter, right in the ascending, transverse descending colons, and possibly in the rectum and the sigmoid there. So all this is actually, fecal loading, yes. It's mottled, appearance of, fecal residue here. We do have a bit of air, or a bit of air within the large bowels, but I think the fecal residue has taken predominance in this case. So when you see that, I think people do give some kind of enemas to treat that. On the right side here, we have a very thick fecal residue arising from the rectum right into maybe the proximal part of the sigmoid. And look at the consistent texture of this fecal residue here. So this is what they call fecal impaction. So there is a retained fecal residue here, which is quite large, consistent, solid, and extending from the rectum right into the sigmoid. Sometimes it can even go into the descending colon as well. So when you see that, usually institutionalized patients or patients possibly in very sick patients, or immobile patients, they tend to have these kind of fecal impaction. The elderly patients tend to have this kind of fecal impaction. Should we be doing X-rays for fecal impaction? Some centers don't. Some centers do, because they say that this can be diagnosed by PR method. Right. So calcifications can be classified as those that are quite significant, and those which are insignificant calcifications. So significant calcifications include cholelithiasis or gallbladder stones, which we can see over here. You can also see a porcelain gallbladder here. So when you see these are significant calcifications. Another significant calcification will be the Steigerhorns, or renal calculi, or you can see ureteric, or maybe renal calculi, you may also see ureteric calculi, possibly within the anatomy of the ureters, or possibly at the vesico-ureteric junctions, and all those. You must be looking for those ones, because these become significant calcifications, which we need to be shouting out. This one is the urinary bladder. Urinary bladder stones, they tend to be quite smooth, flat. There could be multiple of these. So when you see them, they're very smooth. They are within the bladder area. So these will be the bladder stones. Down here also, we may have insignificant calcifications. Phlebolytes would be another thing that possibly when you see them again, they are insignificant findings. So some reporters don't even comment on the phlebolytes, but they will comment on these calculi, calcifications. Significant calcifications again would include nephrocalcinosis. Nephrocalcinosis again just becomes the widespread or diffuse calcification of the kidney parenchyma. So usually they tend to be quite bilateral in this case. So we've got a bilateral calcification of the kidney parenchyma. So that again becomes nephrocalcinosis. Patients who tend to be alcoholics, I think they tend to also have pancreatic problems. They may have calcified pancreas. So in this case here, we do have multifoci calcific deposits, central, possibly overshadowing L2, right, in the middle. So in this case here, it corresponds to the anatomy where you can find the pancreas. So in this case here, this patient's got pancreatic calcifications. Possibly patient has got pancreatitis. This has to be investigated further. You could do possibly an ultrasound. You could do other tests, to confirm, presence of, pancreatitis. So central calcifications in this case here, in the area of L1, L2, L3 there, confirms, pancreatic calcifications, possibly secondary to pancreatitis there. We do have, adrenal calcifications. These are triangular calcifications right in the, superior to the kidneys. So they tend to be quite triangular. They're very rare actually, but when you see them, they look like that. And then these are as a result of possibly, somebody could have adrenal hemorrhage in the past, or they may have had tuberculosis. Those are the ones that I know possibly that could cause, adrenal calcifications, adrenal hemorrhage, and previous attack of, tuberculosis as well. So adrenal calcifications are quite significant findings. When you see them, call them out. Over here, we do have, in the middle, we do have atherosclerosis. There is, aortic calcification. The aorta is actually calcified and it is actually dilated. So we can see that, there is actually widening of the descending aorta here at the level of L3, L4. And when you measure the diameter of the aorta, I think it shouldn't be on an X-ray. It shouldn't be more than 5 millimeters, 5 millimeters, 5 centimeters. I've forgotten actually. Five. I think it's 5. Don't quote me on this one. I think it's to be 5 centimeters, I think. If it is more than that, there is actually an aneurysm. So in this case here, this patient has got an aneurysmal infrarenal abdominal aorta here. So this is actually, aneurysmal here. Notice here that, we do have the delineation of the psoas muscles. You are able to see the contours of the psoas muscles. If you see the contours of the psoas muscles with an aneurysm, you should be calling it out, but this is, when you see it, it's good news for the patient because they might have, surgical intervention. On the left here, we do have an aneurysmal aorta here. It's quite large, but notice that we are missing the psoas muscles. So when we miss the psoas muscles, again, it means look at the texture around the aorta here. So the texture is actually white, a bit whitish here, and then we can't see the psoas muscle contours and stuff. When we see this, with this grayish appearance around here, one can be correct to assume that this has ruptured. So when we lose the contours of the psoas muscles on an abdominal X-ray, whereby you do have grayish appearance surrounding it, and you have lost the contours of the psoas muscles, you could be correct to say that I think we are dealing with a ruptured aorta aneurysm, aortic aneurysm. Notice in the middle here, we do have the contours of that. Again, I must mention here that an abscess in the psoas muscle could distort the appearances of the psoas muscles. Again, the clinical features that the patient is presenting with, fever, any signs of infection. When we do an abdominal X-ray, you can't see that. This patient possibly, maybe they might have, an abscess, in the psoas muscles. Possibly, your center possibly could do an MRI scan, or they could do a CT scan, possibly to rule out, things, like that. But usually, with an abdominal aortic aneurysm, with absence of psoas muscle, outlines and things like that, you would be correct to assume or suspect, a ruptured, aortic aneurysm. On the right here, obviously, I did these kind of X-rays when I was practicing clinically, in Ndola. So we could do pregnant women to look out for fetal presentation, multiplicity, and spotting signs. But nowadays, obviously, because of the ultrasound, availability of ultrasound, so these X-rays are never done. But you never know. You never know. Somebody could be pregnant and they don't know that they're pregnant. If you do an X-ray on somebody who is an innocent child, they've been taken, advantage of, child abuse kind of, cases. I wouldn't be surprised that you might see, a pregnant, abdomen. So look out for for these ones, particularly in female patients. These are significant calcifications. Insignificant calcifications include phlebolysis, like I mentioned. So these ones are phlebolysis. They tend to be characterized by a very sclerotic border around with a central lucency. So look at that. There's a sclerotic rim around with a central lucency. So phlebolysis tends to present in that kind of format. In the middle here, we do have calcified lymph node, mesenteric lymph nodes, possibly due to previous infections. They tend to be all over in the midline. When you do a chest X-ray, again, chest X-rays again would give us this kind of lymph node calcifications, particularly within the lymph nodes surrounding the mediastinum kind of. And then on the right here, we do have a well circumscribed soft calcified soft tissue density in the region of the within the pelvic cavity. So this again becomes leiomyoma, or some people obviously will call it the uterine fibroid calcification. So that's what it is. And then down on the left side here, we do have calcified splenic vessels. Again, these are insignificant calcifications that we need to be looking out for. Other insignificant calcifications would include splenic cysts. Those are insignificant. They're quite common. When done abdominal X-ray, it will be well circumscribed and with no aggressive features. Disability, you'll be looking out for the bones and the solid organs. What are you going to be looking out for? You'll be looking for fractures. You'll be looking for destructive bone lesions, which could either be osteoblastic or osteolytic lesions within the skeletal anatomy of the area that you've x-rayed. You'll be looking at the spine, looking for things like destructive bone lesions there. You'll be looking for fractures. You'll be looking for spondylotic changes. You'll be looking for features of ankylosing spondylitis. You'll be looking for features like what they call the, if you do laterals, you'll be looking for things like, osteoarthritis. You'll be looking out for things like, dish, features and all those. And then you'll also be looking for solid organ enlargement. So here are the examples. So in this case here, we do have the pelvic x-ray, we cropped obviously the rest of the abdomen, but you can see that you do have the fractures to the left superior and inferior pubic rami. So these fractures can be missed. If you are concentrating on other anatomical areas, you might miss the fractures of the bony architecture. Also look out for the greater trochanters. You might see, missed fractures, or you may see destructive bone lesions. Look out for the sacrum. You might miss, chordomas or destructive bone lesions lying across there. You might miss also the stress fractures, of the sacrum. On the right here, we do have, increased patchy, irregular, increased bony densities spread across the entire pelvis and the proximal femora. So in this case here, these are ill-defined osteoblastic lesions. And then look at the L5 here. L5, it has increased density here. There's too much, bone turnover, osteoblastic activity going on with the pelvis, lower lumbar spine and the proximal femora here. So this, you'd be correct if it's a male patient, that to say this could be secondary to prostate cancer. So don't just look out for other, features, abdominal bowels and all those other things, but also look at the bone anatomy. Look at this spine here. Last time we spoke about the spine, I was talking about the importance of you appreciating the posterior elements. So these are the pedicles. We need to see the pedicles at all levels. But at L4 here, L3, 1, 2, 3, L3, we are missing a pedicle over here. So when you're missing a pedicle here, cancer tend to have the affinity of destroying the pedicles. So when you see a loss of a pedicle on a lumbar, thoracic, whatever, that is a destructive bone lesion. So this has to be investigated further because this actually is malignancy here. We're losing that, we're losing the pedicle there. Over here, we also have a destructive bone lesion, which has destroyed the right to superior pubic ramus. Look at how ill-defined this one is. So there is some kind of, osteolytic, activity here, osteoclastic activity going on here. So this is more of bone cancer here. Look at the spine here. The spine here is what is called the dagger sign or bamboo appearance. And we do have the sacroiliac joints have been fused. They have been ankylosed because of ankylosing spondylitis. So ankylosing spondylitis is quite common, possibly in young, young adults. So basically people in their maybe 30s, 20s, 40, kind of, 50s, is quite common, but it's quite common to see this kind of dagger appearance on an AP, when you do an abdominal x-ray, again, when you see ankylosing spondylitis, you've got to call it out. One of the things that, ankylosing spondylitis tend to do is that, you might have, the ossification along the anterior longitudinal ligament. It might fracture. So patient will be complaining of pain in the back. So when you do a lateral lumbar spine or T-spine, X-ray, or even a C-spine, you may see that the anterior longitudinal, the calcified anterior longitudinal ligament is going to be fractured. So that could explain the patient's symptoms and things like that. So in this case, if this patient was presenting with pain in the back, we've done the X-ray of the abdomen and we see that, you'd be within your right to do a lateral to see whether, the discontinuity to the calcified or ossified, anterior or posterior longitudinal ligaments and things like that. So that's what it is. Solid organs enlargement, we can see that, the tip of the right, lobe is actually nearly touching the iliac crest here. So this is the radial, lobe. It's really more like a tongue, really coming down here. So this becomes an enlarged, lobe of the liver. On the other side here, we do have an enlarged, well-circumscribed soft tissue mass, well-circumscribed, possibly to the left upper abdominal quadrant, possibly in the region of the left kidney, which possibly could be a renal cyst. So this one, again, if we saw that, you could either do an ultrasound scan or possibly do a CT scan if depending on your protocol, really. So ultrasound could be okay, CT scan can be okay as well. So that's what it is. On the other side here, we do have, look at this. We are missing the centrally located small bowels. They are not there on this radiograph on the right side here. We are missing it. But look at that. We have everything have been pushed, outside, towards the periphery. We can see the large bowels there. And then the small bowels have also been pushed. And look at the uniform density around here. So this is actually a mass effect. This is a mass effect, which is causing things to be pushed away. So it is actually arising from the pelvis itself and pushing things away from the center. So this becomes possibly a cyst, possibly arising from the pelvis. So again, ultrasound could be useful to characterize or possibly look at what's causing this. So if your center allows you to do CT scan, this is another patient to whom we can do a CT scan or even an ultrasound to characterize the nature of the mass itself. If this patient had ascites would push the bowels, inferiorly towards the pelvis. So all these would be causing, they'll be pushed down towards the pelvis, and then the X-ray will be more grayish around here. So when you see all that, by just looking at the position of the bowels and the gray appearance up here, you would be right to call out that as, ascites itself. But in this case here, it's arising from the pelvis and pushing things outside towards the right side. We would be right to say that things could be, possibly, a cyst, possibly gynecological in nature. So we could do an ultrasound to rule out that. Okay, so over here, we spoke about that. Again, we can also look at, things that could be surgical interventions. For example, somebody has had a metallic stent put in. So basically, maybe this patient may have had, the pancreatic head, could have a cancer. So somebody could have a pancreatic head cancer here. So they've put in a stent here just to make the biliary duct, a bit, patent, as it were. So in this case here, usually patients with these kind of, interventions tend to have, pancreatic head, cancers and things like that. And then we do have the another stent here. It's more or less like a pigtail kind of, stent. These are also interventions that you can see. On the right here, again, we can see the duodenal, stent. Possibly somebody might have had, duodenal cancer. And then obviously to make it a bit more patent, people tend to put, those kind of, stents. So you can see stents anywhere in the abdomen, as it were. Look at this. This is a patient with a large of the EVA stent, as it were. So that is an EVA stent. EVA stents, obviously, in your center, people tend to even do a lateral projection for these ones. You'll be looking for migration of these, stents. This is an IVC filter. Again, this is a common finding, at least, where I am. So these are quite common, findings. So IVC filter, tend to be in that region there. So when you see them, obviously, you may have to compare, the position of the IVC filter with regards to the previous imaging, and possibly comment that there is no migration of the stent. If it is migrating, obviously that becomes one of the things that people need to be looking at. So you have got to compare and make a statement. Just that I think it has maintained its previous position, as we know when you compare that with the post immediate or intraoperative imaging, as it were. These again are IUCDs. IUCDs, can migrate. Sometimes this can come out, or it may change its position, or you might even surprisingly see it possibly beneath the hemidiaphragms. So sometimes when people do ultrasound scans for these ones, they might lose it. So when they lose it, they may ask for an abdominal X-ray. With an abdominal X-ray, you might see this one possibly could migrate, and then it has to be reported as such. So ever since I started reporting these, I think I've seen possibly about 5 or 6. So these ones do migrate as well, or they can come out, things like that. And possibly, again, you never know what, you can do. You see when somebody has had, sometimes, patients do insert things in their rectums. So this was actually inserted in the rectum for whatever reasons. And then this is, again, I think, a mobile phone inserted in somebody's rectum. So these things do happen. Sometimes you may see a knife, you may see anything, in the rectum, people inserting all those things. And then on the right here, this was a drug dealer. Obviously, they swallowed, condoms of filled with drugs. So these are drugs. Somebody wanted to smuggle drugs, and then they swallowed all these things. So we can see multiple well circumscribed kind of, masses. So all these are just pellets of drugs that somebody had swallowed. So again, if you are reporting these ones, again, you might be an expert witness if this case went to court. So you'll be able to sort of when you report these ones, you see them, you suspect this could be whatever. So you could be called upon as an expert witness to give your leveled, expert opinion regarding what you are seeing and things like that. So basically, this one with confidence, somebody can say that now these are pellets of multiple soft tissue masses, well circumscribed soft tissue masses spread across the ascending, transverse, descending, sigmoid and the rectum. So possibly consistent with the, drugs, as it were. So in this case here, this is what you can see. I think on that note here, I chopped out a few things, and I think this has been my presentation. I'm happy to take any questions, and thank you very much for listening. I thank you. Thank you very much.
Well, thank you very much, Mr. Mike, for this wonderful presentation. Allow me to invite people who may have some questions or contributions before we progress. If you have a question or a contribution, kindly raise your hand, then we'll be able to notice you and ask your question.